coming to component sizing. So past we used various jigs and there were subjective errors in sizing the implants, especially the femur. Presently we are using robotics. So there's again a paper which states that femoral component sizing in Oxford knee does not work for Indian patients. So this is published in 2019 in Journal of Knee Surgery. So now presently we are doing with robotics. So with robotics we know that it's more accurate. You can exactly size the implant depending upon your landmarks. Coming to planning, past there was no actual planning. We used to take tibial cut, then proximal cut is the most important cut for the uni, and then the femur preparation follows the tibial cut. So tibial cut is the landmark cut, and from there on there are sequential steps which we do to make sure that our femur and tibia are going hand in hand, and when we balance it accordingly. And the femur sizing was with the spoon, so if you don't place the spoon properly, you had errors. Presently, we are doing all this planning with the help of robotics. We can move the component distally, we can change the angle, we can proximalize the tibia or distalize the femur, you can take it posterior. So all this is what we are doing present. And gap planning in present scenario with robotic UKR is very good. So there's a simple algorithm. If your balance is very tight, you can move your tibial component inferiorly or reduce the thickness of the poly. So these are the various scenarios which we all know. We can very well do it with the robotic UKR. And you can play around with the implant. You can exactly see how your gap is changing. You can exactly monitor how tight it was previously, and after changing the implant placement, how are you getting the graph. So this is the advantage of using robotic in the present scenario, and the UKR has become very simple. Also, when you see the ML position adjustment, you can see where your point contacts are in robotics. So you can exactly localize where your femur and tibia will come in contact. Throughout the range of motion, you can see when you're flexing the knee, you can see what points are coming in contact and how you want to change that. You can medialize or lateralize the component to match the area where you're looking at. And in the past, the tibial resection, it is the most important step. It was the most important step for UKR. Since it's a smaller incision, so there are more errors, and the tibial slope is very difficult to access and judge when you doing it with a conventional manner. And there's also a high chance of MCL injury when you're taking the saw cut through a very small incision. Present scenario, the tibial resection is very simple. It's with a burr. There's a minimal chance of soft tissue damage, including the MCL. And you can exactly calculate how much slope do you want, and you can achieve that target by using a robotic device. Also, in the past, the femoral component which followed the tibial cut as a base, since if your tibia is wrong, everything will go up wrong, and the femur will just follow your tibial cut. Presently, with robotics, we are using high-speed burr, and we're getting exact resection of the femur, exact amount which you want, not even a millimeter more. And the alignment and the angle of the cut also is perfect. So post-op gap balance, initially we all were using eyeballing. We used to see, yeah, it looks good, it is perfect, and we used to say, yeah, it's done. And presently, with robotics, we are using checking the whole range, and then we are giving varus and valgus stress, and we are quantifying how your gaps are, and we can actually get a objective measure on the screen how your gaps are changing and whether you're able to balance it or not. So this is the advantage of using a uni with robotics. So when we did a conventional UKR, we used to think it is perfect, on table looks perfect, but when you do X-ray, it looks like this. So we all had our share of complications or bad looking X-rays using Oxford knee, and or any other conventional knee. So X-rays were looking like this post-op. And then you think about, my surgery went very well, but how is the X-ray looking like that? But with present robotic, all X-rays will look perfect, all X-rays will be well aligned, and the poly size thickness you can target, and it will be the same for all your X-rays. In fact, all your X-rays will look exactly a mirror image of each other. So what about the future? I think we are the future is now, and the future is here. So we are already in future, and we're doing the best for the uni in terms of using robotics. Thank you.